So good evening, good afternoon to wherever everyone is. Today we're going to talk about neurological assessment and management. So this is going to be one of your focused assessments for the OSCE. So as always, please stop me if you have any questions or anything that we need to clarify. Let me know. AVPU, it stands for alert, verbal, pain, and unresponsiveness. And really, these are just the mnemonics that we use to gauge our patient's level of conscious. So it's a quick way to determine our patient's level of consciousness there. So, if you start talking to your patient, introducing yourself, asking them basic questions like, can you tell me your name? If they're able to understand your questions and engage, okay, then they are deemed as being an alert and conscious. Whereas if you are having to repeat your questionnaires to your patient, then that would mean that your patient is only responding to verbal stimulus, okay? And painful stimulus is if you're performing a painful stimuli to the patient to elicit a response, then that would be the P, and then if the patient's unresponsive, then that's DU. So again, this is a quick way to gauge our patient's level of consciousness, and this is part of your vital signs. So if you have a look at your SAGO chart here, down at the bottom, it'll say disability under neurological. So you just either put a dot or a tick at whichever your patient's responding to.
So we're going to use BFAST. So how are we going to do this assessment? Again, I think we say BFAST, but we're actually using FAST in our assessment, which is okay. Angelina, do you want us to use FAST? Go ahead with FAST. Okay. All right. So we're going to use FAST. So again, how do you check for the facial droop or the facial asymmetry? You can ask the patient to smile. And when they smile, you can look at the teeth on both sides. If someone smiles and you can see more teeth on one side, but less on the other side, there's a asymmetry. Also, there's a nasolabial fold, which is referred to as the fold here. Can you all see where I'm pointing? So this may be lower in one case and upper in one case, and there's definitely a facial droop. And that's again a sign of your stroke. Next, you'll check for the arm strength. Again, you can ask the patient to raise both arms and see if there's one lower than the other. Or you can also check for the motor assessment, which we spoke about, from shoulder to elbows to your wrist. And then you document which part is weaker. So patient may have shoulder weakness, but may not have weakness in the elbow or the arms or the wrist. And that could be due to a previous, say, for example, shoulder surgery. But if there's a weakness, you document that there's a weakness and you can find out the reason later. Then also you'll check for speech. So, but quick method, because you're only using FAST, not the GCS, quick method will be either get them to squeeze your hand or hold their arms up. That'll be quickest one for the FAST to use. Next will be your speech. So you're already talking to the patient. You're talking to them, asking their name, see if it's making sense what they're saying, or does family has to intervene because patient cannot answer, or family will tell you it's like a word salad, or they're not able to find the right word, or they're slurring their words. So different ways they can use to describe. So when you're talking to the patient, are you able to understand what they're saying? Are their answers according to the questions you're asking, or they're talking about something different altogether? Be mindful of patients from a culturally and linguistic diverse background. Be mindful if they've got a history of dementia. So collateral from the family is important. If patients come from nursing home, always refer to the notes from the nursing home to see what their baseline function is or level of consciousness is. Then again, time is really important. If you think this patient's having a stroke, can I give one more story very quickly? This will help you remember this. So there was a patient in our ward. Patient was 67 years old, came in with pyelonephritis, which is the infection of the kidney. And he was fine. He was admitted because they were really worried about his kidneys and all that. Nurses did his observation at 10 p.m. at night, 3 a.m. in the morning. He was fine. He was walking to the toilet. He came back to bed. They did set of observations. At 3 a.m. again, nurse went back to check on the patient to do more obs. And when she was doing the obs, he couldn't lift his left arm. So he was having stroke 3 a.m. in the morning, and they had to escalate. So she used FAST very quickly. She knew patient was having a stroke. So that's why it's very important to use these assessment tools. Someone's got a question.
Sorry, can I just add that the BFAS is being taught at the universities? So I'm not quite sure whether whether OSCE has now adopted the BFAS, but the BFAS is it's been taught in the universities for the last year. So it's just a matter of whether OSCE has caught up to using BFAS or FAS.
For consistency, in my opinion, I think our students should be using BFAS. That will give them the edge, and I would think that it would score higher that we're using updated ones. And thank you, Simpi, for introducing that, and everyone for giving us the updated one taught in our universities here.
And the local health districts are also using BFAS.
Thank you.
Okay, so just if you're using BFAS, so when you're checking for the balance, again, balance could be anything. It could be dizziness. It could be leaning on one side. It could be loss of balance, like ataxia, that they're not keeping up, their gait's not right, one foot's not matching with the other. It could be any of the things. Again, it does come down to your order of questioning as the time of onset, whether it's acute onset or whether it's something. The reason being, they could still be having a stroke if it's 2 weeks old. They've just presented late. It's not that urgent then. It's still urgent because someone who's had a stroke has got a high risk of having another stroke. So you do need to put preventative strategies in place, but they're not candidate for really, really hyperacute stroke care, which is very time bounded. So if they've passed 4.5 hours, they're not the candidate for thrombolysis treatment or thrombolysis. But up to 24 hours, they can still be a candidate for thrombectomy. So it's really still important we identify these symptoms right. Again, these symptoms are more common if the patient's having posterior circulation, stroke, balance, and eye. As I said, 80% of patients will have FAST, which is the anterior circulation of the brain. So balance, they'll lose coordination. Maybe they might say, my coordination's off. Again, with the eye, you specifically have to ask them whether it's a double vision they're having, have the lost vision in one eye, or they can't see. So you can do a test on them as well, or family is usually able to tell you, and patient will be able to tell you as well. So it's asking the right questions important. And dizziness, usually by itself, with no other symptoms, is usually not a sign of stroke. But I would not say that I've never seen one patient who had dizziness alone and had a stroke. But it's usually other questions you would ask with, we call them 5 Ds of posterior circulation. So you'll ask them if they have any dysarthria, which is slurring of the words, or diplopia, or if they've got dystaxia or ataxia, which is the balance, or diplopia. So do you ask other questions with them? Is that making sense for anyone, or am I going too fast, or is it random for you, or do you want me to repeat it?